But first of all, let me introduce myself. I'm Dr. Petros Grivas. I'm a medical oncologist at Seattle Cancer Care Alliance. I'm an associate professor at the University of Washington and Fred Hutchinson Cancer Research Center. Very excited to be part of the PROSCA and BLADDR meeting this year. And I'm also very excited because next year we hopefully will have these meetings in Athens, Greece in October 2022. So stay tuned for that. I would say that we're very excited about the PROOF 302 trial. This is a randomized phase 3 trial with patients who had radical nephroureterectomy or ureterectomy or radical cystectomy and lymph node dissection in either case, who have high risk of recurrence that is defined based on the pathologic states, and they get randomized to either Infigratinib, an FGFR3 inhibitor, or placebo for 1 year of treatment, with the primary endpoint being disease-free survival. Secondary endpoints include overall survival, safety, and patients may or not have received neoadjuvant cisplatin-based chemotherapy, and depending on the pathologic stage, they could be eligible for the study depending on the risk of recurrence. Patients are pre-screened based on the tumor tissue from the radical surgery, radical nephroureterectomy or cystectomy, and the tumor tissue should have an FGFR3 susceptible alteration, either mutation or fusion rearrangement that is activating. And based on this screening and other eligibility criteria that we outlined in the trial in progress, patients can go on the study. The study is still ongoing. The accrual is ongoing, and the study is open in many centers. And we're very, very excited about this opportunity. Many people are asking how the recent FDA approval of nivolumab adjuvantly in the United States impacts the landscape. I think we have to discuss with our patients, and offer the FDA-approved agent as an option. At the same time, there are many questions regarding the efficacy and the impact, especially in the adjuvant setting, in the context of an FGFR3 activating alteration. I think the data in metastatic urothelial cancer, raises questions, and the question is the efficacy of checkpoint inhibitors the same in patients with those FGFR3 alterations? And there is a lot of evolving literature about this topic. So in the context of this, evolving literature and the potentially distinct biology of these tumors, I think it's reasonable to discuss, both adjuvant nivolumab and the PROOF 302 trial in patients who have high risk of recurrence based on the pathologic stage. And the other point is we have data obviously from the POUT trial from Dr. Brittle and colleagues in the upper tract disease, resect upper tract disease with adjuvant platinum gemcitabine that showed progression-free survival, disease-free survival benefit, and the trend towards overall survival for patients who never received neoadjuvant chemo for upper tract disease, but got adjuvant chemotherapy versus no chemotherapy. And I think that data is important. This data are relevant for patients who never received neoadjuvant chemo. So you have to think about the existing data sets and patients who already had received neoadjuvant chemotherapy. Neoadjuvantly, there is no strong evidence to use more adjuvant. So those who already received neoadjuvant chemo, they can go to either the PROOF 302 trial or adjuvant nivolumab, or if neither is an option for contraindications, then can go on observation. But patients who never received neoadjuvant chemo, you have to think about, is this patient fit for cisplatin or not, especially for bladder cancer, and then put that into context of your options for the patient. So in that context, PROOF 302 is a very exciting trial in the adjuvant setting, still ongoing, and I think it's important to generate knowledge about it.